Hello everyone, my name is Aman and I'm currently a foundation doctor working within City and Stanwell hospitals. I'll be doing this short lecture today about delirium. I'll start by explaining what delirium is and the features of it. I'll go on to explain some tools that you can use to help you assess if a patient is delirious or not. I'll talk about the causes, and then finally how you can manage this yourselves and also within your teams. I'll be very concise and highlight the key points which I believe are mostly relevant to you when you start practicing in the clinical environment. So to start, what is delirium and is it important? Delirium is extremely important because it's extremely common. In between 2017 and 2018, there were over 350,000 cases of delirium happening either during a patient's stay or as a reason for them coming into hospital. So you'll no doubt be tasked with identifying and managing this when you clock patients in and when you're managing them on your ward. Remember, the elderly are at risk or most at risk of delirium, and the average hospital patient is elderly. You may have heard of delirium being referred to as the acute confusional state, and this is where there's a change in a patient's baseline alertness and awareness. The ICD-10 is a fantastic tool, and there's one focused on mental and behavioral disorders. This breaks down delirium in some detail and highlights some key features that separate it from other pathologies. So these include a reduced ability to focus. If you speak to someone who is confused or has delirium, they have a hard time keeping track of the conversation and they're very easily distracted. There's an element of disorientation, so they may not be able to tell you what time of day it is, where they are, or who you are. And there's an impairment of their immediate memory recall. If you speak to them in the morning and then go to them again in the afternoon, they may not be able to remember what you spoke about earlier on in the day. There's a psychomotor change, so we categorize delirium as hypoactive, hyperactive, and then patients can fluctuate between the two. I'll speak about this in more detail on the next slide. All of these things occur very quickly. This typically means it can happen over weeks, but more often over days to hours. This is a key feature that separates it from, for example, dementia, which is a chronic cognitive impairment and takes months and years to develop. There can be an element of sleep disturbance, so when you go to the wards at night time, you might find patients wide awake sitting at the nurse's station or wandering about. This insomnia and disruption of the sleep-wake cycle can be a feature of delirium. And there's an organic cause, which means when you investigate, either through bloods and imaging, you find a reason that's driving the sudden change in behavior. Typically it's infection, but it can be other things as well. If there's no identifiable organic cause, then it could mean that actually this change in behavior is due to a step down in underlying dementia, or could represent an underlying psychiatric problem. So what are the features of delirium then? In addition to the previous features that I spoke about, we can categorize delirium as hypoactive and hyperactive. So hypoactive delirium is a reduction in the level of activity where patients can be drowsy, have a reduced intake, so not eat or drink as much, and their level of engagement is poor compared to usual. Hyperactive delirium is much more easily recognized because patients get agitated, aggressive, and can lash out. They may have hallucinations, and their reactions or speed of speech is a lot quicker. Patients can fluctuate between the two, so they can show signs of both at different times of the day, and so it's important to be aware of both. How do you know if somebody is delirious then? There's some tools that you can use to help you assess these patients. One of them is the confusion assessment method. So this is detailed in the picture here. In order to diagnose someone with delirium by this method, they need to have features of A and B and one of C or D. And these features we've already touched on, so things happening or this change of behavior occurring acutely. There's some inattention there where they get easily distracted or it's hard to focus. There's some disorganized thinking where when they're answering your questions, it doesn't make sense, it's off topic. And then there can be an altered level of consciousness, which is the hypoactive and hyperactive features. This method uses a combination of observation and also engaging with the patient as well. Another common test that's used is the AMT, or abbreviated mental test. When you clock patients in, you can do the AMT4, where you ask the patient their age, date of birth, where they think they are, and what they believe the current year is. In theory, if they score less than 4 out of 4, then that can spark you to undertake further cognitive testing or flag that there could be some confusion. The AMT10 is more detailed and has more questions, and these include things like naming the current Prime Minister or who the current monarch is, and you ask the patients a significant event, so a year in which World War I ended or World War II ended. In addition, you ask them to recall an address, so you might ask 3 questions and then give them an address to try and remember, such as 42 West Street, and then once you ask a few more questions, you see if they can try and recall that address, and that's a test of their immediate memory recall. A score by the scoring criteria of 7 or more is okay. If they score 4 to 6, then that's moderate cognitive impairment, and anything less than 4, so 0 to 3, is severe cognitive impairment. This can mean that there's either delirium there, or there's an element of chronic cognitive impairment, such as dementia. You must interpret these on a case-by-case basis. Some people simply may not know the years of the ending of World War I or World War II. And in some cases, patients can be at their normal, so not confused or delirious, but still not score correctly. If you're ever unsure or it's hard to interpret, you can ask a senior or you can ask family. So asking sons or daughters or next of kin what that patient's normal baseline is like will give you a good idea of what to expect from that patient and if these patients need further investigating or not. So what are some of the causes then? The acronym that I use is VOMITED. I'm sure there's many more out there that run through causes of delirium, but I'll go through my one in more detail. So V is vascular, strokes or bleeds or even TIAs. Always be wary of the patients who have been with you for a long time on your ward and have had a fall or you suspect may have fallen, because the elderly are at risk of subdural hemorrhages, which take some time to develop and they can cause a change of behavior later on down the line. This may warrant imaging such as CT scanning. O is occult, so hidden things that are not immediately obvious. These aren't so common, but things to consider in the appropriate clinical context. Things like cerebral tumours or rarely cerebral abscesses. M is metabolic, so by metabolic we refer to things on the blood panel. So commonly changes in electrolytes, especially hyper and hyponatremia or hypercalcemia. Hypoxia from infections such as chest infections. Liver failure from any cause because of hepatic encephalopathy, where there's a buildup of ammonia. And then I've put constipation and urinary retention here. These are easy to recognize and pick up on, and very easily reversible causes of delirium. Constipation and urinary retention can have a profound impact in the elderly and create changes in behavior that wouldn't occur in younger people. It's always good to check whenever you see patients and examine them when they last managed to open their bowels and if they're passing urine okay. As I say, they're very easily reversible and you can prevent these from being culprits of delirium early on. I is infection, and this is extremely common as well. Urinary tract infections, respiratory tract infections are both very common. Encephalitis is not so common, but something to consider if you've ruled other things out. And if you're ever suspecting infection, then manage appropriately by thinking sepsis and using the sepsis 6. Toxins such as alcohol. Anybody can withdraw from alcohol, and delirium tremens is a consequence of that. And then medications, we should always try and refine the drug chart where possible. Sedatives such as lorazepam and hypnotics like zopiclone can be common culprits of confusion and drowsiness. Antidepressants and neuropathic painkillers are alike, and then steroids as well. Is endocrine, so some things here are common, some things are not so common. I've put stress here. If you ever work a surgical job, patients that have quite significant surgeries such as laparotomies or significant orthopedic surgeries can experience something called post-surgical delirium. This is something to consider and something you might pick up on. But remember, always investigate to see if their surgery is causing any infection or other issues. Changes in blood sugar, so significant hypo or hyperglycemia, and commonly hypothyroidism. And then the adrenals as well. So if people have been on steroids for a long time and their doses don't get increased during infection and stress, or they're withdrawn from steroids, they can go through an Addisonian crisis. This is not so common, but always think of it if someone is on steroids, because it can cause changes in their blood pressure and make them unwell. And then D is deficiency. So as part of the confusion screen, we check for B12, folate and iron, and deficiencies in any of these can in theory cause changes in behavior. Always consider other things. So these following can mimic delirium but are not quite fitting under the categories that I've mentioned. So epilepsy, because of the post-ictal phase, whenever somebody has an epileptic seizure, they can go through a phase where immediately afterwards they're drowsy, confused. Alcohol withdrawal, which I've mentioned, and then mania, psychosis and dementia. So these are underlying problems which don't have an organic cause that you find when you investigate. Consider these in the appropriate context. How can you manage delirium then? I say manage and not treat because the management of delirium is holistic and it can take a long time to settle, so it can require medical intervention as well as careful communication with other teams and family members. Always get collateral information. Make sure that this patient is or isn't at their baseline before you decide to investigate further. Simple things like orientating the patient with hearing aids or giving them glasses can make a difference. And you can always call family members in to give them some familiarity and help calm and settle the patients down. A medical workup will involve an examination to look for any focus of infection, as infection is a very, very common cause of delirium. And as I say, always ask if they're passing urine and opening their bowels. In terms of blood work, the confusion screen involves basic bloods, such as the full blood count, U's&E's and CRP, and then checking their electrolytes, as well as their thyroid function, their B12, folate and iron, and we replace these as necessary. In elderly, because urine dips aren't reliable, we always send for urine MC&S instead, and we can do a chest x-ray to look for any consolidation. And if the previous haven't really shown much, you can consider a CT head to look for any acute events such as strokes or bleeds. Assess the drug chart and see if there are any recently started drugs which could be the culprit, or any background drugs that were pre-admission that could also be contributing towards alterations in behaviour. If things are still quite difficult to manage, especially in hyperactive delirium, such as agitation, aggression, patients not being adherent, and it's very difficult to take bloods or do cannulas, then you can go for medical measures. So these include haloperidol and lorazepam. Haloperidol is typically first line, but be aware of contraindications such as Parkinson's disease and Lewy body dementia. Lorazepam is the alternative. So that's that. These are the objectives that we've addressed during this presentation. So we've gone through what delirium is and the features, tools that you can use to help you work out if somebody's delirious or not and how to interpret them. We've addressed some causes and then some management methods as well. These are some of the references I've used. The Oxford Handbook is an excellent source. Thank you very much for listening.